All right. 54-year-old female came in with facial swelling. So a patient was a 54-year-old, no known medical history, came into the ED with facial swelling of a few hours duration. She said that in the morning she was just drinking her coffee and then started noticing painless swelling of her face, chest, and arms. So she called EMS because she thought she was having an allergic reaction. En route, EMS placed her on a BiPAP and gave her epinephrine and Solumedrol and Benadryl. Despite these interventions, the swelling progressed. Okay. Do you want to ask any question before I move to the next slide?
We can do a quick go through of all the historical slides.
Okay, I'll do that. Okay. So she had some shortness of breath, minimally, no chest pain, abdominal pain, or back pain, no fevers or chills, no recent trauma. She wasn't complaining of throat swelling or difficulty swallowing or tongue swelling or neck pain, no rash, no erythema, no wheals, no nausea, vomiting, or diarrhea, and no previous episodes. As I said, no medical history, no surgical history, no family history, non-smoker, works as a teacher, she's single, no alcohol or drug use, no home meds, and no known allergies. And that's the review of system. It was only positive for the facial swelling.
Now, at this point, would anybody have any more questions?
I assume she has had coffee before and she never had facial swelling. Is that correct?
Yep, she was just drinking her morning coffee and it started.
Can you talk about the distribution a little bit, Madeline?
The swelling?
The distribution, facial swelling, was it involving the oral mucosa, like the mouth?
It was all over her face, like her face, her eyes, her mouth, her cheeks, her neck, everywhere.
Has this ever happened to this patient before?
No.
I know that you said no allergic reaction. Okay, thank you.
Anna,
was there like erythema or plethora?
No erythema, no rash.
Anna's asking any recent travel?
No recent travel.
Any fever?
No fevers or chills.
How fast like the swallowing developed?
It was progressive over a few hours. It became a few hours.
Okay. Any food besides the coffee? This was after the patient took coffee, but did the patient take any food before that?
No, not really. She was setting herself to start eating, but with the coffee she started having it. And it was nothing new.
In her coffee? No?
Nothing new in that coffee.
Okay, thank you.
The shortness of breath, is it progressing or is it stable?
So she would say to one physician, she would say she's short of breath. To another, she would say, no, I'm fine. So it was really minimal shortness of breath, but it was there because she had some work of breathing.
Do we know why the EMS placed her on BiPAP?
It said in one of the notes that they thought that she was wheezing, and so they just put her on BiPAP, and because she was breathing a bit fast, they put her on BiPAP. But there was no documentation of hypoxia or anything like that.
Was she able to swallow?
She's able to swallow.
Was she like outside or like any like insect bites or in the garden? No.
All right, I think in the interest of time, let's move forward.
Okay. So that's the physical exam. Her blood pressure was 195 over 124, tachycardic to 120, tachypneic to 40, afebrile, and saturating 95% on room air. She was diffusely swollen with mildly increased work of breathing, but not in distress. Diffuse facial, head, neck swelling with crepitus. No tongue swelling or intraoral lesions. Diffuse crepitus of the neck, no stridor. Significantly diminished breath sounds bilaterally with mild increased work of breathing. Tachycardic, regular distant heart sounds. Diffuse swelling and crepitus of the chest, abdomen, and upper extremities and proximal lower extremities. Neuro exam was non-focal.
Andrew asks in the chat, any recent dental work?
Any recent what?
Dental work? Did you go to the dentist?
Mm-mm.
At this point, just everybody has, I hope everybody's looked at the vitals. Does anybody want to comment on the blood pressure and heart rate? Anything which comes to mind?
How about good or bad?
Good or bad, or like something which
I'm just saying anything. Someone answer or call on someone.
I was thinking about anaphylaxis, and you usually see hypotension, so I was expecting to see some comments right now.
But maybe the patient is hypertensive because it's in acute distress, or maybe it's because the swelling is affecting.
Now that we're on this slide again, look at the last line. The patient got something, right? The patient got epinephrine. So if the patient gets epinephrine, they're going to be tachycardic. They're going to have a high blood pressure. So if we don't know what, if the patient had anaphylaxis or not, but something that, if you see these lab findings, these are not natural. This is either somebody in really, really bad distress who's going to die right now. But since the patient has mildly increased work of breathing, the fact that these vitals are so off doesn't really correlate, right? So you have to think this might just be related to what the patient just got. Any more things on examination you would have elicited in this case, or you would have looked for?
I gotta say, a respiratory rate of 40 is not a mildly increased work of breathing, right?
Yeah, she was.
If that's a true number.
I don't know how much you can trust this number. She was a bit tachypneic, not for. I wouldn't say 40. I would say in the 30s maybe.
Yeah. I mean, a lot of times the respiratory rate, especially in the triage sheets and in the ED, that's a number you just, you have to see.
Yeah, just look over.
Because you don't really have too many people, especially in the ED, who are going to be, counting breaths. So you have to always do a respiratory rate for yourself.
How about the rest of the lung exam, like beside the breathe sounds? It's like.
Noor, would you have any specific findings you're looking for?
Like, was there like tympanic, like dullness, like on percussion, or is there like this vibration or like what stuff that can help?
It was hyperresonant and no tactile affirmative. A lot of tactile affirmative.
Where was the diffuse swelling and crepitus on her chest? Was it just around the upper neck?
Or it was all over, all the way from her face, neck, chest, abdomen, proximal lower extremities, and upper extremities.
All right. Any other questions?
Can I ask what she was doing before breakfast? Had she had any, sexual activity before breakfast?
She said she did not.
Okay.
Any rashes, like her skin?
No.
I'm sorry if you said smoking, Madeline, did you?
No, no smoker, not a smoker.
All right.
Any recent vomiting?
Nope.
Any JVD?
Any JVD?
No, jugular venous distension, neck veins.
I don't think the ED did it, and no, it wasn't there. There was a lot of crepitus on the neck.
Any history of pneumothorax?
No history of it.
Okay. Any visible goiter, or it was just diffuse neck swelling?
Diffuse neck swelling was crepitus.
And any recent endoscopies or like any procedure?
Great question. No.
And there was no pain when she swallowed, correct?
No pain when swallowing. Nope. Everything. It was all painless.
Okay. And no recent procedures, like involving the chest?
Nope.
So for this swelling, if you had to estimate, like how swollen was her chest and abdomen and all of that?
I guess you'll see on imaging. I don't know.
Okay. But it's like very significant?
Yep.
Okay.
All right, let's move forward. Let's talk about problem representation. Who's going to take a shot? or I'll just call out somebody. Vincent, can you help us with problem representation?
Yes. So we have a middle-aged female who present with acute diffuse swelling with shortness of breath. Physical exam was significant for diffuse swelling and decreased breath sounds bilaterally, tachycardic and hypertensive, likely from epinephrine. And yeah.
In this case, I just add she was also, you have to take the vitals with the caveat that she's been treated empirically for anaphylaxis. So that would be important because in isolation, those vitals could mean something else, but in this context, it means something else. But yeah, Madeline, you can go ahead.
Oh, okay. Do you want to ask for labs, or should I just tell you what the labs show?
Just show us the labs. You don't have too much time.
Oh, okay. All right. So here, other than the labs, you'll see in red there are prices. The prices are the NIH rate, which is the minimum, and the standard Mount Sinai rate, which is the maximum. Keep in mind that the standard Mount Sinai rate is just the one that they charge, but then it depends on if a patient doesn't have insurance. If they're uninsured, then this is the rate. But then sometimes they do some discounts. If they have insurance, then it depends on what the insurance bargains with Sinai. And it's not like usually if we say CBC $96, for Blue Cross Blue Shield, it's not $96. For UMR, it's going to be different. So this one, the Mount Sinai rate, the standard one is negotiable, but the minimum is what you should just keep in mind, that this is about the range of the price of the labs. So her white count was 27.9. VBG with lactate 7.23, PCO2 76 with a lactate of 2, and trope was 0.022, UA was negative. Creatinine was fine. Did you want to ask for any other labs?
Anything else in the workup? What else? What's the first thing you would want in this case?
X-ray?
Yes, X-ray.
Okay. If you wanted an EKG, it showed sign stack. This is the X-ray. What
Oh,
do you
wow.
think of it?
Does she lift weights? Does she do any weightlifting?
No. I don't think so.
Does anybody want to take a, or just, I don't do it systematically, just what do you see? What's staring at us?
There is a lot of subcutaneous emphysema involving the breasts, the base of the neck. I don't see, and there is also, is that, oh no, that's the scapula, that's not.
It's really hard to see, I think, the outline if you're trying to look for pneumothorax in either of those.
Yeah, I have a hard
you
time
can-
seeing the outline too.
I think you might be able to see it on the left lung. There might be that
Oh
outline.
yeah, like below the scapula. Like,
yeah, or you think it's the scapula. Okay, but the other thing was that you see a lot of opacities, even through the emphysema, I think, of the skin. It looks like she might have bilateral opacities, although again, hard to tell.
Yeah, I agree. I mean, you can obviously, the subcutaneous emphysema is like hitting you in the face, but the lung fields are really, really hard to, I mean, I can't make anything out of them.
Yeah, maybe an ultrasound will be good if we could focus her and see if there is a pneumothorax.
All right. So you guys are right. You see the neck. You see all the black is air, where it shouldn't be. All the black is air. All the black is air. Even here, extremities, all the black is air. And when you see the striations of the muscle, that means air in the muscle. It's a typical sign of subcutaneous emphysema. And you see the striations of the pectoralis. I don't know if this is why you asked if she lifts weight, but this is because there's air in the muscle. And you can't really see the pneumo here, or if there's a pneumo, because of the massive subcutaneous emphysema. Here's the CT.
Oh, nice. Oh.
So you see there's a moderate left-sided pneumothorax with trace pleural effusions and extensive subacute emphysema in the soft tissue of the neck, chest, abdomen, bilateral upper extremities, and proximal thighs with pneumomediastinum. And the exact etiology was not identified, but there were also some solid, some pulmonary nodules with ground glass opacities. On review of the CT, at the beginning, the read did not say anything about it, but on review a few days later, they did say that there were multiple mildly displaced acute posterior left-sided rib fractures in the 9th, 10th, and 11th rib. That's the CT neck.
Those rib fractures were new?
Yes, they were new. The patient denied trauma, denied anything like that, so sorry. The question about these rib fractures was
I mean, is there anything you would be worried about in a patient that has rib fractures, has this, and is denying anything?
yeah, of course. Yeah. She said she does not have a partner.
I mean, you would be worried though that she was assaulted, oral sex sometimes, especially forcible oral sex, can lead to median stenitis and also subacute emphysema. So you would worry that she was sexually assaulted and she's not, you know, admitting it for safety reasons or something else.
So this case was new. Actually, Matthew Alexander gave me the case, and she's still being worked up now. So she was only in the hospital 3 weeks ago. So everything's still being worked up. So the diagnosis is tension pneumothorax with pneumomediastinum and extensive subcutaneous emphysema. The etiology is unclear. So we are calling it traumatic because of the rib fractures, but also she has possible underlying lung disease, small airway disease with these ground glass opacities and the nodules that we don't know about.
Is it possible it was exacerbated by the BiPAP in the ambulance?
Of course, it was exacerbated by the BiPAP, yep. For someone with pneumothorax, you should not give positive pressure ventilation. You know, like you remember in the ICU, when we have someone with pneumothorax, we put minimum PEEP, some 0 or very minimal.
In this patient, we obviously think it's traumatic, but if this was, you know, there was no suspicion for trauma, is there anything else in the examination you would like look for which predisposes these patients to spontaneous pneumothoraces? Or not in her, like if it was a young male, what would be a risk factor for spontaneous pneumothorax?
Emphysema and pleb, congenital diseases.
Yeah, the usual phenotype is somebody who's extremely tall, could be marfanoid, and they're the ones who are at risk for spontaneous pneumothorax. But this obviously is not in that picture, but you know, obviously this needs more workup. But we can go ahead and talk about your theoretical slides.
Okay, so I'm gonna define pneumothorax. You know that it's gas and within the pleural cavity.
Can I ask what happened to the patient? Did they like do chest tubes, or how they manage it?
Yep. They put
bilateral chest tubes, or one, or
nope, left-sided. It was a left-sided pneumo. They put a left-sided chest tube and they gave her supplemental oxygen, so she was on a non-rebreather to help displace the nitrogen into the blood and help the gas exchange. But the emphysema will take months and months and months to resolve.
Yeah, so like we were not sure why she was put on BiPAP to begin with, and that probably exacerbated whatever, you know, her initial pneumothorax so bad. Anyway, cool.
Yeah. All right, so you see here, this is just an example of pneumothorax. On the left, you'll see this the pneumothorax is here. There's no lung markings, and then you see a shift, a mediastinal shift. The trachea, heart, and mediastinum, and then they put a chest tube. See here, they put a chest tube, and then you'll see the lining of the lung. Okay. So simple pneumothorax is the one without a mediastinal shift to the contralateral side, and most importantly, patient is clinically and hemodynamically stable. Tension pneumo is when there is air in the pleural space that builds up enough pressure to interfere with venous return, leading to hypotension, tachycardia, severe dyspnea, and sometimes altered mental status. So the reason why is it says one-way valve mechanism. So the gas is going into the pleural space, but not exiting. And so that's why the pressure builds up and causes the decreased venous return. These patients with tension pneumo, they need immediate decompression, either with a needle decompression or chest tube insertion. Can also classify it depending on etiology. So primary spontaneous pneumothorax, secondary spontaneous pneumothorax, and traumatic or iatrogenic pneumothorax. The primary spontaneous one is what Angad was saying, that the characteristic patient, young, male, tall, thin, usually is a pleural bleb or bulla ruptures. Cigarette smoking is a known risk factor to an increase, and the risk increases with more exposure to smoke. Secondary spontaneous pneumothorax is the pneumothorax in a patient with underlying lung disease. These patients usually don't have enough reserve. They don't have enough physiological reserve because of the underlying lung disease. So they usually come in more critical and with more tachypnea, tachycardia, and all that. Usually COPDers. So these are the causes of secondary spontaneous pneumo, airway disease like COPD, infectious lung disease like necrotizing pneumonia like a staph pneumonia, interstitial lung disease like sarcoid, connective tissue disease like Marfan or Ehlers-Danlos, cancer, lung cancer, sarcoma, and thoracic endometriosis. Traumatic or iatrogenic pneumothorax is what we hope we don't do when we're putting a central line. It's a penetrating or blunt trauma to the chest, like when you're placing a pleural catheter or central line. You know that. So this is an up-to-date table. It's very nice. It's very busy. I'm not gonna go over it, but if you want to refer to it later, they show like secondary spontaneous COPD, cystic fibrosis, malignancy, infection, iatrogenic, traumatic, miscellaneous. The cool one is the scuba diving and air travel, exercise, anorexia. Okay, and the clinical presentation in spontaneous pneumo, usually patients will tell you they're at rest, like this patient, and then they have sudden onset dyspnea with ipsilateral pleuritic chest pain. The chest pain is not very common though, and occasionally it develops during exercise, air travel, scuba diving, or when they're using drugs. If they have hemodynamic compromise, that should raise the suspicion for tension pneumothorax. On physical exam, like Noor was asking, what were we hearing besides the absent breath sounds? It's loss of tactile fremitus. Percussion will be hyperresonant with subacute emphysema. Tracheal deviation away from the affected side may be present if the pneumothorax is large or if it's tension. On inspection, there will be decreased diaphragmatic excursion on the affected side with reduction in chest wall expansion. Tachycardia, tachypnea, hypotension, and hypoxia are intention pneumo. Subacute emphysema and crepitus, you should evaluate for a pneumothorax. Ruptured esophagus, someone asked if had a recent endoscopy or laryngopharyngeal injury. And also someone asked if we're vomiting like a Borhoff syndrome or something, or laryngopharyngeal injury. Other investigations, myeloleukocytosis with left shift. This patient had a white count of 27. Possible hypoxia depending on the size of the pneumo. EKG, either sinus tach like this patient, or if they become bradycardic or severely hypoxemic, indicating tension pneumo with impending collapse, cardiovascular collapse. So it's a radiographic diagnosis. It's based on imaging. Usually we do a chest x-ray. It's the most common modality used. And there are guidelines to see if it's a small or large pneumo. And also in the ED, the fast exam and ultrasound, if someone is experienced in ultrasound, you can see the pneumo. You will see there will be no lung sliding, possible lung point or transition point, and the barcode sign on M mode. The treatment is decompression, so either by needle aspiration or chest tube placement. Oxygen therapy, which is what pulmonary team had the patient on, was a non-rebreather. So you administer supplemental oxygen, it will displace nitrogen from the blood and create a gradient of gas that will promote resorption from the pleural space, the air from the pleural space and into the blood. Recurrent primary spontaneous pneumothorax would require a definitive procedure to prevent recurrence, like pleurodesis. And with patients with secondary spontaneous pneumothorax, usually they should be hospitalized and they require interventions. We should emphasize again, no positive pressure ventilation for patients with a pneumothorax. It will make it worse. So when intubated, no or minimal PEEP and no BiPAP. Okay, I don't think this is very relevant, but usually if a patient is upright, you'll see the pneumothorax in the apical area. If the patient is in the ICU and supine, you might not find the pneumo on the apical area. You can see the deep sulcus sign or the claustrophrenic sulcus. And if in the lateral decubitus, it will go to the non-dependent lateral location. Other types, hydropneumothorax is when you have both fluid and air, and the pneumothorax ex vacuo is what, oh wait, sorry, I think I deleted it. But anyway, pneumothorax ex vacuo is when the lung gets trapped. So when you do a thoracentesis and you remove fluids and then the lung is trying to expand, but it gets trapped by thick fibrous pleural urines. So it does not fully expand and then you have a pneumothorax ex vacuo. So this patient came back to clinic about 2 days ago. They repeated the CT chest and it showed interval resolution of the left pneumothorax and pneumomediastinum, but she still had facial swelling, neck swelling. It needs months to resolve. She had mild reduction in the scattered ground glass opacities and nodules, but they're still there and they're still trying to figure out what these are. And the rib fractures are partially healed. So when she was in the hospital, she was discharged on home oxygen because when she was ambulating, she was desaturating. So she's still on home oxygen a month later. Key points: subacute emphysema and crepitus on exam should warrant workup for pneumothorax, laryngopharyngeal injury, or esophageal rupture. And if too severe, it can cause upper airway obstruction. So in this patient, she came in and we thought it was an allergic reaction. So subacute air can subacute emphysema, if it's too severe, it can cause shortness of breath and upper airway obstruction. So do a proper physical exam and see the crepitus the crepitus is a big sign. Pneumothorax is a radiographic diagnosis, but tension pneumo is a clinical one. Tachycardia, hypotension, hypoxia, possible altered mental status. Management is decompression and oxygen therapy mainly, and avoid positive pressure ventilation in patients with pneumothorax.
I just have a comment for this lady. She have like fractures for multiple reps without pain. So does this raise any concern for any underlying disease like osteoporosis or malignancy?
Yeah, she's getting worked up, especially for a malignancy.
No, I also want to say there are certain subpopulations where if you get a pneumothorax, you obviously have to think about other things because suppose you have a patient with HIV who comes with a pneumothorax. Is there anything which could put them at risk? Any patient with HIV or AIDS? Exactly.
Yeah, that would be PCP.
So
also TB.
TB, yeah. So it depends on your subpopulation. If you have somebody who's like old, has had, exposure to some kind of occupational exposure, what would you think? So some certain kinds of ILDs can also cause higher risk for pneumothorax. So you always have to see what subpopulation you're dealing with, and in those, and before you label it as a spontaneous pneumothorax, you always have to make sure there's no other cause of which could predispose you to pneumothorax. Especially this patient, obviously we don't have enough data, we don't know what's going on, and obviously needs more workup. But always try to get to the bottom of why this patient would be at high risk for pneumothorax.
I would still be very suspicious about abuse, though, for somebody with fractures and a pneumo on the same side, because it's also possible. I mean, it didn't look like they were incredibly displaced, but right, sometimes fractures from trauma can give you a pneumo just with the ribs being very sharp at the edges. So I don't know. That's still very, very suspicious.
Yeah. not just abuse, but also, you know, certain psychiatric disorders or something which would, you know, so this patient's having trauma and you're not knowing about it, alcohol abuse, you know, and any kind of psychoactive substance use could also be predisposing this patient to polytrauma.
I mean, something doesn't make sense because if you just come in with a pneumo, you might need oxygen while it's there, but you don't need oxygen to go home. So why is she requiring oxygen? That doesn't make any sense.
Unclear. We don't know. Palm are following, but she missed her palm appointment. And not clear. It says small airway disease, these ground glass opacities, and the nodules. Well, not sure, but she did not follow up with palm.
That's okay. You have some parenchymal disease going on, which needs to be evaluated, but yeah, at this point, we don't really have enough data. But interesting case that you can have, you know, when you think of swelling, you should always do a full examination. And, you know, if you have any suspicion of barotrauma, then obviously putting the patient on positive airway pressure is going to worsen the patient rather than improve them. So that's something to keep in mind. Any other questions?
Yeah, for me, the elephant in this Zoom would be the price range of this test. Oh my goodness.
Yeah. Yes, please be aware of the prices. I know we had a very difficult time finding the prices, but Dr. Singh is amazing and she got them. But look at one CBC, how much it can be, CMP, how much it can be, and we order them on a daily basis. And sometimes on rounds, we order them for patients that we know they don't need them, but we just order them just in case. The just in case for patients that are uninsured, that do not have money or have very, very high deductibles. Look at how much one lab will cost. So please put it in the back of your mind. We're not saying that we shouldn't order it if it's not necessary, but for those patients that on daily rounds, we're just ordering labs just because the patient is paying for it.
And another common practice is, as residents, when you place admission orders, you automatically place orders for a week,
7 days.
Morning labs for a week. I think daily reassessment, I think as you go over patients' orders, I think you need to reassess every day. They need labs.
Please do.
And even if the patient is not paying for it, we're all paying for it, right? Because even people that have insurance, when we're using all these useless tests, right, it all goes into the same bucket. So you're all being charged higher costs for your insurance through CIR because of all this useless lab test ordering.
Well, I would just put it from the consultant row, like also making sure you're ordering the right test and not a CBC platelet, but a CBC differential if you're actually monitoring the white count. So I think just also when you order, not just ordering the cheapest, but making sure you're also ordering the correct test if you're going to order it at all.
A CBC with platelet will range 8 to 60.
And I know I always harp on this, but think about all the tests you guys order that the patient gets discharged and no one ever follows up on, right? Because you guys don't follow up on them after the patient leaves. The primary care doctor may not have access to Epic, so no one ever looks at those tests that are resulting, that take more than a few days to come back and the patient's gone.
And a classic example is someone ordered a few years ago, this is a while back, ordered an HIV viral load because they were trying to rule out just like, you know, why this person was regarding their differential. And it came back positive, but the lab didn't call because they thought this patient was just someone that had been off their meds. And they got the ID fellow in this case was actually following and saw it. But otherwise, there was no report of it because the lab didn't call because they just thought it was, you know, someone that just hadn't taken their meds.
I mean, the price is set. I mean, there's a whole way prices are set, right? But the list price is never what the hospital is receiving. And the list price is usually based on what the Medicare rate is. And then, you know, Medicaid usually will pay about 5 to 10% of Medicare. Private insurances will usually pay about 150 to 175% of Medicare, which is why a hospital has to have a nice balance of uninsured patients and insured patients. And then there's a whole bucket of uncovered care that the state has at the end of the year that we get reimbursed for because we're a safety net hospital for a lot of the uncovered care. I forget what it's called, but it's shared amongst all the hospitals that accept those types of things. Like Sloan doesn't get any of that money because it doesn't accept Medicaid. But there is a bucket of money that the government gets for, unreimbursed care where the patient doesn't have any insurance. But that's where the general price comes from to start with, is from the Medicare rate, and then everything bends around that. And we're a nonprofit hospital, so we're not trying to make a profit, but we do have to pay our bills, right? So there's no mission if you don't have money. So
all right. If no other comments or questions, we can call it a day. Thank you, everybody. Thank you, Madelin, for this presentation. And thank you, everybody, for joining.